Let me ask you this. What if I offered you an operation that could give you years of better pain and function, but it might not last forever? Would you take it? That is exactly the tension that this paper helps us answer. Welcome to Sunday Paper Roundup, where I read the papers so you don't have to. Colombia. I spent a lot of my life dealing with the consequences of meniscus deficiency. At Cleveland Clinic London, my partner Tim Spalding and I do meniscus transplants routinely. It's generally not a common operation in orthopedics. It is technically demanding. It often sits alongside realignment osteotomy, sometimes revision ACL reconstruction, sometimes cartilage restoration, and it depends on graft access and availability as well. So when a paper looks at what happens to meniscus transplants beyond 10 years, I pay attention. This week I'm showing love for the Journal of Isicos, and it feels especially relevant because the senior author in this paper is Volker Musal, who's now the new deputy editor of the journal. Volker is based out of the Freddie Fu Center for Sports Medicine in Pittsburgh, Pennsylvania, and he's a great guy. Freddie Fu sadly passed away a few years ago as one of the true giants for sports knee surgery. We all stand on his shoulders, pour out some liquor. Another author in this paper is Darren DeSar from McMaster in Hamilton, and I had the privilege to meeting Darren when he was an ISCOS traveling fellow, and he's doing great work. Now to the paper, because this is a subject that I care deeply about. If you follow my content, you know that I always say, save the meniscus, save the world. And if you can't save it, then, in the right patient, you should at least be thinking about whether you can replace it, because the meniscus is absolutely vital for joint health. This week's paper is a systematic review and meta-analysis looking at meniscus transplantation with more than 10 years of follow-up. They included 20 studies with over 1,000 patients and a mean follow-up of just over 12 years. The headline finding is balanced but important. Meniscus allograft transplantation, or MAT, maintains pain relief, function, and activity beyond 10 years. So yes, meniscus transplant works. We know that time and time again. It can help knee symptoms and knee longevity. It can protect and preserve cartilage. It can do so for a meaningful period of time. But it's not all rainbows and unicorns. The pooled objective failure rate was 31%, and the pooled rate of conversion to knee replacement was 17%. So this is not a forever operation. We're always very open and transparent about that. It's not magic, and it's not something you offer casually. But in the right patient, the symptomatic meniscus deficient knee without advanced degeneration, this is still a very important joint preserving option, ideally before the onset of overload, cartilage wear, and early arthritis. That's the key message. Biomechanically, it just makes sense. The meniscus matters. It matters for load distribution, shock absorption, stability, and cartilage protection. So when it's gone, the whole joint changes and shit goes downhill. That's why I get so animated about saving the meniscus, because I spend so much of my life dealing with the consequences of meniscal deficiency, and some people still underestimate how important the meniscus really is. And that's why there are times we really should intervene surgically to save the meniscus. Now, what does this paper get right? Well, first, it gives us long-term data. That immediately makes it valuable. Lots of operations look good at 2 years. Plenty still look decent at 5. But once you get beyond 10 years, the truth starts to show itself. Where's she at? Where's she at? Second, this is a systematic review and meta-analysis, which gives it more weight than another isolated case series. Third, the tone is mature. It doesn't oversell meniscus transplant. It says outcomes are maintained, but failure is moderate, and patient selection and counselling matter. That's exactly right. Now let's head to the critical analysis. The included studies were mostly level 3 and 4. So this is not high-level randomized evidence. It's mostly cohort data and case series, which means selection bias is a real issue. These are not your generic knee patients. These are highly selected patients, usually symptomatic, often treated in specialist centers, often having additional procedures. So the results are useful, but they're not automatically generalizable to everyone. Second, there was real heterogeneity, different cartilage status, different alignment, different rates of osteotomy, different ligament status, different graft preservation methods, different fixation techniques, and even different rehab protocols. So whilst the pool numbers are useful, they're also blending together a lot of very different knees. Third, the definition of failure varied, and that's one of the biggest weaknesses in the paper. Some studies counted graft tear, some counted graft removal, some counted revision surgery, some counted knee replacement, and some counted poor functional scores. So when you hear 31% failure, that's helpful, but it's not one perfectly clean endpoint. Fourth, the paper is strong on prompts, but weaker on the deeper structural question. Are we truly changing the natural history of the knee? Or are we buying time? Now, to be clear, buying time in the right young patient can be hugely valuable. That's not trivial. That could be their whole 20s, 30s, and 40s. That could be marriage, parenthood, so many life events. It's not just a matter of whacking in a graft. The difficult part is often the entire knee, the alignment, the instability, the cartilage status, previous tunnels and revision ACL cases, and whether the knee is even biologically and mechanically salvageable. That's why this is niche work. That's why results in specialist centers matter, but are not always easy to reproduce everywhere. So for me, the take home is simple. If the meniscus is repairable, repair it. But if it's not repairable and the patient becomes truly meniscus deficient and symptomatic, then do not pretend that is benign. Think carefully about restoration, think carefully about alignment, think carefully about cartilage, the stability, think carefully about the whole knee, because the real question is not, does a meniscus transplant last forever? Clearly it doesn't, and we don't pretend otherwise, but the better question is, can it buy meaningful years of better pain and function and help preserve the joint in the right patient for the medium to long term? And this paper suggests the answer is yes, often it can. So what's my verdict from this paper? Should we ignore it? Should we be aware of it? Should we consider it? Or should we go right ahead and change your practice? Well, my verdict, be aware of it and consider it seriously. not as a miracle, not as a bailout for every post-meniscectomy knee, but as a valuable joint-preserving tool in the right patient, with the right indication, in the right hands, and with the right counseling and the right rehab. Because if you can save the meniscus, save it. And if you can't save it, then replacing it may still be one of the best things that we can do. And so refer them on accordingly to the right person. I'll see you next Sunday. I'll keep breaking down the evidence as it lands.